All right. Good evening, everyone, and thank you for joining us for our first joint NPhA and SNPhA legislative event. I am Sienna Miller, and I am the legislative chair for the National Pharmaceutical Association. Joining with me from the Student National Pharmaceutical Association is Jasmine Perry, and her current role is a legislative membership benefits and immigration chair. Jasmine and I will be moderating this evening's event. We are excited to have you with us today. In today's session, we will have two expert speakers that will be providing information on current legislative issues that have an impact on the minority and underserved communities. Before I hand it off to our first expert speaker, Dr. Sharmon Osai, I want to cover some housekeeping items. All participants are being muted to minimize background noise. Please have your videos off so that all the undivided attention will be towards the speakers. If you have any questions, please feel free to enter them throughout the presentation in the chat, and they will be addressed at the end of today's session. If anything comes up that we are not able to address during the presentation, feel free to email me at sienna.miller@npha.net, and we will get back to you. Each of the presenters' emails will also be provided at the end of the event. I will now transition to Jasmine as she will lead into the next part of this event this evening.
Thank you so much. So I have the pleasure of introducing our first speaker, Dr. Sharmon Osai. So Dr. Sharmon P. Osai is a clinical assistant professor at the University of Georgia College of Pharmacy. She obtained her PharmD from the University of St. Joseph in 2014 and subsequently completed a PGY1 residency at Harris Health System in Houston, Texas, and a PGY2 residency in ambulatory care and education at the Indianapolis VAMC Purdue University in Indiana. Her clinical practice site is in Phoebe Primary Care Northwest, a family medicine clinic in the heart of Albany, Georgia. A portion of her current responsibilities include a robust drug information service in which she provides answers to healthcare professional questions on various medications, disorders, and conditions, and assists in the optimization of care delivery to their uninsured and underserved patient populations. Her research and scholarly activity interests include educational health disparities, and improving the knowledge of those who deliver care, while improving patient outcomes with a particular interest in patients with diabetes. She is a member of the Health Equity ACCP PRN and delivers an elective course for second and third year pharmacy students entitled Introduction to U.S. Health Disparities. I'm so excited for us to hear tonight, Dr. Osai.
Thank you so much for that introduction. Allow me to share my PowerPoint. So I'm gonna click yes here. Perfect. So I'm super amped to be here with you guys this evening to talk about caring for patients creatively. I want to review health disparities and talk about the importance of advocacy and legislation. Couple of housekeeping tips for me. I do have an audience member here with me this evening. He is my 3-year-old son, Jerome. So if he interrupts me, I ask you for your patience. He's learning on how to be quiet in these types of settings, but super excited. My only other housekeeping tip is for those of you who have never used Poll Everywhere before, I'll be using that functionality in my conversation with you this evening. So I'll have 2 Poll Everywhere questions that I'm going to ask you guys to respond to, and I look forward to hearing those responses. So a little bit of interactiveness. So let's go ahead and get started. I have nothing to disclose at this time. And I hope by the end of this presentation that no matter where you're starting on your level of health disparities, that you can define health disparities as well as social determinants of health by the time you leave this conversation, and that you're able to identify some strategies for pharmacists to promote health equity from a legislative and advocacy standpoint. We're going to talk a little bit more about that. So everybody is kind of familiar with this little graphic here, this doohickey. COVID-19 has put a really big emphasis on health disparities, right? But they've always been here. They're as American as apple pie, perhaps baseball. They are pretty well ingrained, and they've been documented for decades and reflect longstanding structural and systemic inequities. But one of the things to consider is that they tend to be highlighted when health disparities are associated with racial and ethnic issues. And what it actually one of the things I want you to consider is that it's not just race or ethnicity associated. It definitely can impact other groups as well. So the first poll everywhere question I want you guys to answer today, if you're texting in, it's going to be to 37607, and you're going to text in my name, Charmone Osai 091. If you're using a browser, you'll type in what's at the top of your screen now. I want you to tell me what types of groups come to mind when you are thinking of groups that may have differences or different obstacles associated with their health care. All right, so I got my first one. I've got veterans. Socioeconomic status might help differentiate some groups. Very good. So for those of you who may have never seen this before, this is called a word cloud. So the more people who send in one specific word, the bigger it'll get. So we've got some ability status. Minorities has come in more than once, which is why it's getting larger. Native Americans is coming in. Very good. So you guys are thinking about these different types of groups, disenfranchised. Nice. So thank you for engaging with me. I'm loving how this is working. So again, various different types of groups, not just specific to racial or ethnic, okay? Let's see if we've got any more coming. Minorities is getting real big. People we're all agreeing there. Ability, gender. So I hadn't seen gender before. Flowing in, very nice job. So with that said, yes, Jerome. No, but I need you to sit and watch your tablet. Excuse me, guys. Thanks for your patience. So I'm going to go ahead and move forward to the next slide. Thank you for your answers here. So you guys named a lot of these groups, right? We've got them by age, we've got them by gender, geographic location. I don't think I saw that one. So rural communities might have some disparities associated with them. Socioeconomic status, we saw poor. So a lot of different types of groups. And what's important to notice here, I need you to stop. What's important to notice here is that these groups that are experiencing these disparities are not mutually exclusive. It can occur within subgroups or they can intersect. And so you have perhaps African-American or Black children who may have disparities associated with asthma. So again, these groups can intersect here. So the other thing to think through or understand is social determinants of health. And when we talk about social determinants of health, I usually use the framework from Healthy People 2030 and the other longstanding decades. They have 5 domains. And I want to go through those with you guys to give you an idea of the things in life that can impact a patient's health outside of their own actions, because a person's behaviors can't be considered the only avenue to eliminating health disparities or improving their health outcomes. That individual's behavior takes part in a social environment, right? And so to address health disparities or to improve health outcomes, we need to incorporate those social, political, economic factors which directly impact that person's health, regardless of what they're doing. So the first category here, social and community context, really embodies and includes civic participation, so getting involved in your community, incarceration, and discrimination. This second, economic stability, includes things such as being employed or whether or not employment is present, stability in housing, as well as food insecurity, and then whether or not patients are impoverished or living in poverty. The third category I want to talk about is education, access, and quality. And so that's kind of foundational, right? Talking about our early childhood education, literacy in general. So I know us in healthcare, we talk a lot about health literacy, but literacy in general tends to be important for doing most anything in this world, as well as language. Our demographics are changing. Not everyone speaks English as a first language. So how are we incorporating that into the things in the healthcare that we deliver to patients? And finally, higher education. Our fourth category is healthcare access and quality, and that includes health access to health care, as well as a niche focus into primary care because it has a lot to do with preventive medicine, as well as a niche into health literacy because of course that's important for health outcomes. And the final category that I want to discuss today is neighborhood and built environment. And I left that for last, not because it's least important, but because it was the one that I had the hardest time wrapping my head around. How could man-made structures change how someone's health, right? But it can impact their access to healthy foods if they don't have the stores that they need around to purchase those things. It can impact their health if their housing quality isn't appropriate. And then crime and violence, as well as environmental conditions, can have health income impact. So I'm going to ask my moderators to share this first link for this QR code that I have here in the event that you are watching this presentation on your phone. I want you to scan this if you're not with your phone. This is a activity offered to us from the Robert Wood Johnson Foundation that will stop pulling on this, that will allow you to evaluate how long you live based off of where you live. And so I'm going to give you guys a minute to get it scanned, get your zip codes typed in, and get your answers. So that first box will pop up and it might not have a number in it, but that next one is your county level data, and then followed by your state level data, and then the country level data. And hopefully I've given everyone enough time to get it scanned so I can give an example for any of you who may not be able to do it. So here are my results. I live in Southwest Georgia, Albany, Georgia, as you guys heard. And in my county, my average year of life is 3 years lower than the state as well as the country. And I said to myself, that's a little concerning. Maybe I can try to figure out why. So just really quick, this data is from 2020, and this is the data of self-reported obesity in Georgia. And so for those of you who are geographically challenged like I am, Georgia is in the bottom right-hand corner of the United States. I've highlighted it with a star here for you. And so you'll see here that our self-reported obesity numbers, they're not the highest, but they're not great either, right? Sitting around 30%, correct? And so I dug a little bit deeper because I was like, okay, cool, that's the state, but what does my county look like? If I'm 3 years less, what does that look like just simply from living here? And what they identified was that this is a little bit older data, but back in 2013, my county is where my arrow is pointing. Over half of the people in the county self-reported obesity, a prevalence of obesity. And so obesity is linked with so many different chronic diseases. Therefore, possibly my life might be less. And here's some data that might support it. So neighborhood and built environment, a little bit harder to wrap my head around how that could impact my health outcomes, but these two activities helped me see that a little bit better. And I hope they helped you as well. The final point that I want to make before I get into what we can do and how we can advocate is the financial impact of health disparities. And so interestingly enough, disparities amount to approximately $93 billion in excess medical care costs and $42 billion in lost productivity per year. And so addressing health disparities, it's not only important from a social justice and equity point, but also for improving the nation's overall health and economic prosperity. So let's do a really brief activity. I'm going to give you guys about 3 minutes. We have another QR code here. My moderators will help me drop this into the chat as well, for those of you who may not be able to access it. I want you to meet this patient, and I want you to spend the next 3 minutes. I'm a teacher at heart, you guys. Hopefully this link works. Taking a look at this patient case and thinking in the frame of the SDOH that we just discussed, what are the different concerns that you have as it pertains to social determinants of health for this patient? Go right ahead. So hopefully the QR code has been up there long enough. I'm gonna move on to my next poll everywhere question. I see something dropping in the chat, but I'd love for everyone, if they can't pull up their chat, if they're on their mobile device, go ahead and drop your thoughts as you're reading through looking through this lens of social determinants of health, and you can put in full phrases here. What are you recognizing as it pertains to this patient that's popping up as red flags for you? That might impact his health. Very nice. So I'm seeing some stuff. Herbal medicines greater than prescriptions, can't afford medications, immigrant. Very nice job. You guys are picking out some stuff. I saw something in the chat that said, what's his source of income? He eats cheaper food. He might live in a food desert. Loving the engagement. Concerns with income. As you guys continue to read, we got about 1.5 minutes left to get any thoughts you have. Multiple medications. His education level, very nice. No public transportation. Awesome. All right. And then communication with son can affect continuity of care. I think you guys have hit language barrier. I think you guys have hit everything as you've continued through this sheet, family advice on health. I'm going to go ahead and move forward for sake of time. And just show you guys my thoughts. Of course, I built the case, but again, you guys were able to pick out a lot of the stuff here, right? Low English proficiency, so language, overwhelmed by medications. Maybe that has to do with his education level. He shares a car, he worries about his co-pays. I saw a comment about, his income. He lives in a rural area. I don't know if I saw that specifically, but minimal public transportation. And I don't think I saw the internet purchased meds, but definitely a concern. He eats processed food. You guys said that. And I think the one that we didn't see that can help sometimes with health was that he loves his faith-based community. So civic participation tends to have a positive influence on health outcomes, whereas most of the other ones are associated with negative. So thank you for participating, and nice job being able to pick up on those red flags that maybe you could address with your patients in the future. So very quickly, and again, I am coming up on time. I didn't realize how much of a distraction my son would be, but I wanted to talk about actionable interventions very quickly. And I want to do them in the framework of Healthy People 2030, as well as thinking of it in different levels of advocacy or legislation. And so for economic stability, to help overcome those financial barriers, as well as access barriers, you can think about helping the patient level, whether you're deprescribing or interchanging medications with less costly alternatives. You can think about it at the pharmacist or colleague level, where you're really pushing into professional collaboration, or the system level, where you're encouraging your institution to participate in possibly telehealth, or to really push the narrative of collaborative teams, patient-centered medical homes, to work with your patients. These things can help overcome financial and access barriers. When it comes to neighborhood and built environment, what we're really looking to work on is not only our medical professionals, but our man-made environment as well. So ways to do this at the patient level, as well as the pharmacist level, are to assist with grant writing if we're taking a look at how we can increase funding for different areas or different types of activities for patients to do. And then advocating at a system level could be advocating for increasing individuals practicing in medically underserved areas or populations. So those can be ways that we can help legislate or advocate for patients within our neighborhood and built environment domain. For social and community context, what we're really looking at is 3 main areas, which we're decreasing hesitancy associated with our colleagues as well as patients, but then our own providers as well, because pharmacists tend to state sometimes for advanced practice type things, whether it's pharmacist hormonal contraceptives or naloxone access, hey, I don't really know what I'm doing. I don't feel super comfortable. We have tons of studies that say that. So how do we provide education to our colleagues so that they feel empowered to do what it is that they need to do? And how do we educate the public so that they know that we can practice at the top of our license? Civic participation, it's just getting involved, community brown bags, drug take back days, and then increasing diversity, equity, inclusion across the pharmacy continuum. So that is in tech education throughout pharmacy school, whether it's a PharmD or a graduate level program, and then afterwards in residency training, fellowship training, and beyond, in our own continuing education credits, incorporate it into everything. Coming up towards the end, because I know I'm coming to time, education, access, and quality, lots of different levels to advocate here on as well, where we could increase screening for literacy, health literacy, but literacy in general, provide patient-friendly labels to our patients, and that at a system level, getting our certified medical interpreters and increasing that literacy language and communication research, as well as increasing diversity within our healthcare professional workforce. And finally, in healthcare access and quality, make sure that our care delivery remains innovative and keeps the patient at the center, so that we can ensure that we're delivering the highest quality care. So advocating for innovative care delivery models. That was a lot, and that was really fast. And I'm sorry that I had to rush through that end part, but when we're putting it all together, keep a population-centric mindset. It's not one size fit all of these solutions. And so find what works or what is challenged in your community and work on that within your community, not just because it works somewhere else, is it gonna work there? And then finally, focus on what you have. When we take a mindset of focusing on what we have versus what needs to be found, we can build on our assets and really make a change versus then trying to look for something that may not be currently present. I want to thank my two colleagues for always being ride or die when it comes to things that I need to do health disparity wise, both Dr. Young and Dr. Chastain, and open the floor for any questions. Thank you.
We have about 5 to 8 minutes for questions for Dr. Osai.
And I'm happy to elaborate on any of the legislation or advocacy stuff at this point in the question and answer session, if you find that interesting, because I know I had to rush and I apologize.
Hi, this is Dr. Maribel, president of NPhA. First, I wanted to express my appreciation for you to present to our group, not only for NPhA, but for SNPhA as well. An amazing presentation, as you can see in the chat. You were able to flow very well in such a short period of time. I know that this presentation it has such important points that it can last some time, but you were able to fit it in a very short period of time. So I thank you for that. But my question is, what are some of the ways that, young professionals after they graduate, how can they continue to, be a part of legislative matters in a way that fits into their lifestyle from, coming from being a student to being a working professional? What are some just quick ways that they can continue to be involved and push for policy related issues as a practicing pharmacist?
So the way that I have found to be most, I guess, efficient and effective, as we all are busy professionals, is getting involved in your professional organizations, which you guys are all if you're on this call, right? And so I know that specifically within my ACCP ambulatory care PRN, there is like a legislative committee, and they do so much great stuff. And those types of committees exist in all professional organizations. It's not just ACCP or ASHP or SNPhA, right? So get involved in your professional organization of your choice and really dig in and meet the other individuals who are interested in legislation and advocacy from that viewpoint. And that can help you, if you've never done it at all, get started, or if you are someone who has been doing it since you were in pharmacy school, that can help you progress in that area. So that's my biggest recommendation for getting involved or staying involved is link up with those people, network in those professional organizations. Hopefully that answered your question.
It did. Thank you. Thank you so
You're
much.
welcome. Okay, I have one in the chat. As a student, what resources can we use to have positive impact on underserved communities? What resources can't you use? So I would say reach out to not only your preceptors, honey, I need you to give me a second, please. Reach out to your preceptors, again, professional organizations. So what I love about student organizations is that they have parent organizations, right? Like you have your practitioners who are not your students. So reach out to those parent organizations, see who you can see what types of resources you can garner. And perhaps your preceptors or the individuals or the faculty at your school don't have those resources. And this could be a really cool, I'll put it out there, research project or a paper or something. If there's something that you see that is missing or something that you think could be useful for an underserved community, say that out loud. And perhaps it's some sort of research or some sort of project that you can do that will help that underserved community, but then also kind of just helped you CV-wise and helped you skill-wise and experience-wise. So that's how you can access some of these resources, is to tap into the people who are around you who are either doing it or also have interests in you. Ms. Jasmine, did that answer your question?
Yes, thank you.
Don't pull. Awesome. What other questions do you guys have? Please do not hit your head.
We have about 4 minutes left for questions and answers.
And it's okay if you don't. How can pharmacists gain access to grant writing courses? Reach out to alma maters or local medical groups. So grant writing courses, I've seen some decent ones available from professional organizations. I know that here in Georgia, and I know I'm speaking specifically to where I am, we have an organization called CTSA. I can't remember what it stands for. I think it's Clinical and Translational Science, and I don't know what the A is, but they offer a lot of grant writing resources to the general healthcare provider public. I would have to do some additional research, and I can totally look that up and get back to you for some of my more fervent grant writing colleagues, because it's something that I'm just sticking my toes in the water for now. But I have a lot of colleagues who work in health outcomes research, who grants are their bread and butter. And so I can get you some decent access to how you develop those grant writing skills, because this was just a conversation we were having maybe a week or two ago. So if you've already graduated and you're a young professional, right, possibly you can reach out to your alma maters. I don't know about local medical groups. I do remember that I participated in a program with ACCP. I went to Merit, so it helped you develop research and acumen, but there was another part to it called FIT that dealt with the people who were a little bit higher and really interested in writing grants and stuff. So FIT through ACCP might be a good option, but looking, again, I sound like a broken record, but your professional organizations may have some access to resources, or your professional organization's network might have some people who know where to go for those resources. Hopefully that answered your question. Okay, awesome. So I will tap into my folks in health outcomes and get you guys that information. I'll send it to the mediators. What other questions might you guys have this evening? I've jotted down grant resources for myself to follow up on.
I have a question to close. This is, I guess, to close if we have like about 1 or 2 minutes. So what if, and this is Dr. North, President-elect of the National Pharmaceutical Association. So thank you for your presentation. So often I get, and I am an advocacy fanatic, like I love advocacy and policy, but I think what I hear from most students and early pharmacists is that I'm just not interested in advocacy. I don't understand it. I don't get it. What is the value? Is there like just some closing thoughts about like how easy advocacy can be, or some words of encouragement to those that are looking to tap into it?
So I would say for those who say I don't get it or I don't understand what it's about, I mean, Google, simply Google pharmacist advocacy and take a minute. For all the time we all spend scrolling on all these different news feeds, I would encourage you to take a minute to just take a look at what is out there as it pertains to any professional organization, as it pertains to advocacy, and see how quickly you'll find something that is being advocated for that you are actually interested in. So I would say, just like I would say to any student, keep an open mind. I will say that I was in those shoes, Dr. North, where I was like, meh, advocacy, meh, legislativeness when I was in pharmacy school, but I have found how important it is to really put forth the effort to know what's going on as it pertains to your profession so that you can be a part of continuing to practice at that higher level. And Dr. Brown just put a really great quote, and I'm going to say it if you guys didn't see it. If you're not at the table, you're on the menu. So make yourself aware of what's going on, because if not, you're going to get left behind. And it's really important for you to stay engaged.
All right, thank you so much, Dr. Osai. We appreciate it. I am going to pass it on to my moderator, future Dr. Jasmine Perry, and we will follow up with you. Thank you so much.
Guys, it was really a pleasure. I am gonna run because we got bedtime, but thank you so much. You guys take care.
Thank you, Dr. Osai. Your insight was very valuable, and I really enjoyed your discussion about health disparities within minority and underserved communities. Again, if you guys have any questions, we are going to share her email address at the end of the presentation, so you can feel free to reach out that way. So we do have another guest speaker, Dr. David Shirley. So Dr. David Shirley is an assistant professor with the South Carolina College of Pharmacy, Medical University of South Carolina campus. He received his Doctor of Pharmacy degree from Medical University of South Carolina College of Pharmacy in 2002. He spent 13 years practicing independent community pharmacy in Charleston, South Carolina, specializing in compounded prescriptions. As he has progressed throughout his career, he continues to be active in educating patients and students about proper use of medications. In 2015, Dr. Shirley joined the College of Pharmacy to pursue his love for teaching and mentoring students. Dr. Shirley coordinates pharmacy law and ethics, compounding laboratory, pharmacy communications, and medical terminology courses. He is faculty advisor for National Community Pharmacy Association, MUSC chapter, and involved in other organizations, including Christian Pharmacist Fellowship and Mpha Pharmaceutical Fraternity. Dr. Shirley is a longtime member of the South Carolina Pharmacy Association and served as the president of that organization from 2019 to 2020. Immediate past president, legislative chair from 2021-2022, and currently serves as a member of the legislative committee. He lives in Charleston with his wife, Amy, and two sons, Nate and Camden. And without further ado, Dr. Shirley.
Thank you so much for that introduction. I'm going to share my screen and get started. Maybe. Are you able to see the one slide, or what did I just do?
Yeah, looks good.
So you're seeing a single slide right now, or my presenter view?
Your presenter view.
Okay, there we go. I think that's better.
There we go.
All right, good. So let me back up a second. Thank you so much. What a fantastic presentation. And I think, and I learned a lot. I was excited about it. And I think what follows from my standpoint will be interesting and very supportive and perhaps enlightening. But I'm going to need your help as well. So I want, when we get to the individual bills I'm going to discuss, I want you kind of to help me and put your thinking cap on, because what I'm going to talk about is actually literally where the rubber meets the road. It's going on this week. Our legislators are talking about these things, and we can have an impact. And maybe something we learn tonight may help that process. So before I begin, though, thank you for having me. This is exciting. I have to put a disclosure in here. And the reason I have to is because these bills are actively being discussed. So what I have to tell you, in my background, I am an assistant professor at the College of Pharmacy at Medical University. And I've also been intimately involved with the South Carolina Pharmacy Association. So that state association. And by the way, Georgia has an excellent state association. So tap into that too for those resources you all were talking about. But for tonight's purposes, I have to separate myself and just tell you that what I have on my slides are my opinion. Okay, and the reason I'm doing that is because these bills are actively being discussed. And I just want you to kind of know that. I'm not speaking in an official capacity. I'm just me tonight, okay? But thank you for understanding that. All right, let me go on. Before I get into it, I just want to let you know that in South Carolina here, we are in our sessions for legislative affairs they're 2 years. So this is the second year. So if a bill doesn't make it after this, it's dead. If it doesn't get passed, it's gone. and it'll have to be given a new number and redrafted and so forth. I'm going to be talking about 3 bills, but before I do, I just want to remind all of us what the process is, right? So any organization or somebody who speaks to a legislator can get a bill drafted and sponsored, all right? So that's what you have to do. You have to write it. And we, as a state association, when I was in there, we have written bills and gotten some passed, but you have to get a sponsor. It goes to a subcommittee and then to a full committee. So it's this whole gauntlet it's got to travel. It goes to a full floor, and say it passes the House. It then has to do all of the same stuff again through the Senate side. So it has to travel through 2 of these gauntlets before ever getting to the governor. So just wanted to remind you of that before we begin here. Okay, so there's, and I chose these bills to discuss tonight because the topic was what is going on kind of legislatively in our state, South Carolina, that may impact underserved or underrepresented communities. And of course, all these bills will impact everybody, but specifically, how might it impact those folks? And the 3 bills that are currently kind of being discussed are here, and it's SNPhA Pharmacy, it's narcotic treatment programs, and I mentioned I have a vivid example of why we should be advocates, right, for our profession and for our patients. That's the one, and I'll tell you about that in a minute. Narcotic treatment program, and then birth control. We can talk about that as well because that's kind of front and center these days, and especially in South Carolina, it's gaining a lot of traction. Let's start with SNPhA, and this is the one that is the most confusing. And I could use your help tonight, honestly, because what SNPhA is, and it's being pushed by the chains, it's being pushed by some large wholesalers. What it is if you think of a central pharmacy as the hub and a couple other pharmacies as at the end of the spokes of a wheel, the hub is where it's the SNPhA Pharmacy where prescriptions are processed and filled, maybe even automated in an automated fashion, and then sent to those other pharmacies to get to the patients. Okay, and in South Carolina, what McKesson Drug Company and others are trying to get allowed is a bill that would allow a centralized pharmacy to fill, but they don't send it to the patients, they send it to an existing pharmacy. So one scenario would be, and let's say you had a chain of independent pharmacies. So let's say you own 4 pharmacies around, some are rural, some may not be, but you've got 4 of them. And instead of buying 4 robots because you're getting busy, you want to create a central pharmacy where a big robot's in there and you're chunking out prescriptions for all of these other pharmacies that are out there, right? And they get shipped there. So that's kind of what it is. And you can look at the thing there. The SNPhA bill in our state, South Carolina, is written such that centralized pharmacy cannot send stuff straight to the patients, cannot send prescriptions straight to the patient. It has to go to these pharmacies where the patients then pick up. That is passed subcommittee. It's in the full committee right now in the Senate. And it's got a lot of traction. And I'll be honest with you, as pharmacists, we're having a hard time trying to figure out how this is going to impact folks, especially underserved in rural communities, okay? So what I've done with each of these bills tonight is kind of put a pros and cons as I understand them. And if there's something you can add to this, I covet that. I would love for you to tell me your thoughts on that. But so I've done that with each of the bills. So with SNPhA, some of the good things about it in my mind are, it streamlines costs, right? If we can save money by automating here, then maybe we can retain employees in our pharmacies, and maybe we can keep the pharmacy in business in a rural setting, competing with CVS and Walgreens and all the other big guys. It could possibly allow pharmacies to focus on patient care and counseling. Rural pharmacies maybe can leverage the workforce from a more populated area. So perhaps they have this SNPhA Pharmacy in a populated area of town. So they get, but those prescriptions are sent out to the pharmacy in the rural area, and the costs for that pharmacy are lowered. So that'd be a good thing. And that kind of fits with that last bullet too. But what about the cons? The cons, you know, automating jobs, automation always seems to cost jobs, right? In the automotive industry, robots came in and people lost their jobs. That happens, you know, you might have a pharmacy that's operating with 2 pharmacists and 3 techs, and now suddenly there's a central fill and hey, we only need 1 pharmacist, right? And that hurts everybody. That hurts pharmacy, it hurts the patients that pharmacist served. And what we're seeing already, even without this, is some pharmacy deserts in these areas, right? Even the big chains are shutting their doors. And I know you've seen this in some places. And then will it devolve into the central fill? If we allow that, will it suddenly become a inroads to mail order, right? And so suddenly now you're just mail ordering everything from these regional hubs and you're not caring for these folks. And perhaps less profitable rural or inner city pharmacies may close because of this. So this bill is being discussed this week. And this one in particular, I have a hard time knowing how that it's going to affect rural folks, how it's going to affect underrepresented minorities. I just don't know. These are some of the ideas how it might. And this particular bill, it's hard to figure out how to take a stand, because once you allow it, if as an advocacy organization, which my involvement with the state association, I do a lot of this, if I don't fight and let something go, you know, I've lost my chance kind of, and then it becomes a lot harder. So that's that one. Here's the one that I have spent years, okay? And I'll tell you one thing, getting involved in your professional organizations is so important. But one thing I did not know is as I started climbing the ranks and getting more involved in the State Pharmacy Association, I ended up, once you plug in and become officers of these types of things, whether you like politics or not, you're thrust into it, okay? I had no idea what a world that is. Because I'm one of these guys that likes to please everybody. I don't have enemies, right? I'm not that kind of person. I just, you know, spread love, right? But when you get into positions like this, you're forced to take sides, and you suddenly have people that don't like you very much. And that was hard for me to do as a pharmacist and as just a person in general. But this is called the Methadone Bill. And if you don't, I'm sure you know, but we have methadone clinics, methadone treatment or narcotic treatment programs. And in our state, those programs, in order to dispense and or administer methadone, you have to have a pharmacist present. A pharmacist has to be there to discuss with the patient dosing, drug-drug interactions, you know, reporting of side effects, all of those things. And the clinic owners have been trying, quite frankly, to get rid of pharmacists. And the reason they're doing that, it's a monetary thing. These places have become profitable with Medicaid paying and so forth, and they want to, pharmacists are expensive, and they want to, this bill, what it does is it puts, instead of using pharmacists to do this, it uses the cheapest nurse you can find, which is an LPN, okay? And so that's what they're wanting to do. They're trying to get rid of pharmacists. And there are, I don't know how many, I can't remember how many clinics there are in the state, but there's about 25 to 30 pharmacists that this is their full-time job in South Carolina. Now, I can tell you this, knowing, because I have worked with them directly, and I have fought lawyers and represented many, many hours fighting this. We have killed this bill, I think, 3 times, but it keeps coming back, okay? It keeps coming back. And, you know, some will say, well, there's only 25 pharmacists, so why should we worry about their jobs when we've got all these other things? It's a precedence. We've got to support, it's a patient care thing. This is a patient safety thing. And if you think about this, putting somebody in there for the care of this particular population is very vulnerable, okay? These are folks who won't go to the normal medical practices. They won't go to the authorities. They don't want to complain. And, you know, they're, unfortunately, they have had a drug use disorder and misuse and so forth, and they are vulnerable. And so we need to care for them as best we can. And for patient safety standpoint, a pharmacist being there has been great. Well, they're not going to quit. right? So we do this and we fight it, and we have had victory over it for 2 or 3 years now, and it's coming back. It's coming back each year. So we got to keep after it. So that's that one. So, okay, so I already talked about some of this. The pros, right? If this bill passed and suddenly pharmacists are out the door, the pros are that the clinic owners say they'll build more clinics due to cost savings, and that's likely true. And they can staff more LPNs than pharmacists because of salary differences, about a third of what a pharmacist makes. And so, yeah, there'll be more people there, but it won't be the same care. And there'll be problems. We already know this. There will be problems. So the cons of something like that, removing the drug expert from a very complicated, if any of you know about methadone pharmacokinetics, it's not a simple drug. It's nuanced, and dosing adjustments are necessary, and communicating with patients very necessary. So removing a pharmacist from that population is not a good idea. Medical directors, the physicians, aren't present very much at these clinics, okay? So you're gonna have LPNs running the show, and that's scary to me. They don't have the education that we have. Patient safety, removing an expert, and then it's profit driven. They say it's not, but we know it is. I can't really hide my bias on this one. I can't. I'm sorry. It's been a fight, but it matters to me. And so that's that one. And that's, it's going to have a big effect. And if you think about it, I know you saw the statistic, right? What is a 59% increase in drug overdoses, illicit drug overdoses we've had due to COVID and the stressors there. And so this is not the time to be removing a healthcare professional, a well-educated healthcare professional. This is the time to increase them. Birth control access. This is an easier one. I'm not going to read this, okay? But this bill basically provides a way for pharmacists to prescribe birth control, essentially. We've got, and the protections necessary for us to do that. It also dictates that we get the proper education and so forth. This is gaining traction. It's already been passed in probably 13 to 15 states, but we're talking about it here in South Carolina as well. It's been referred to the big committee, the big medical community in the House. And so we're looking at that. I think with this one, in terms of serving underserved and underrepresented folks, it's pretty easy, more easy to understand, I think, the impact, because one of the things is people in rural communities don't have the access to physicians regularly as people who live in more populated areas. Birth control services through pharmacists have been shown to be very effective. Birth control itself in the forms that this is going to allow is very safe. It increases our opportunity to work with prescribers and work with patients. So it definitely enhances our profession. These are all positives, right? It's although it can be complicated, but it's not generally dangerous, a drug. So we certainly can help with that. The cons, some medical groups, American Medical Association and others tend to oppose this because they tend to oppose anybody. They call it scope creep, or everybody wants a piece of the prescribing pie, and that's not what motivates pharmacists. What motivates pharmacists is working with patients, working at the top of our profession, as Dr. Osai said, and helping our patients, helping. And yes, we want to further our profession, but we're not trying to become physicians. We're not trying to do that. Some of us, pharmacists, some have been practicing a long time, don't really want to do this, and that's okay. The law doesn't require it. The biggie, though, is the chains and their metrics, right? This is just more work for me. This is going to put more stuff just like vaccinations has, and they're not going to pay us more and all of that. That's a con. I get it. It's tough out there for these types of folks. There's always payment concerns and so forth. And the medical people are scared that they will skip appointments with them because the pharmacist is so accessible. It's one thing that I love about being a pharmacist is that we are always so accessible. Just come in and talk to us, right? And we can help without all this red tape. It's great. But those are the things that are going on in South Carolina. Those are the bills that are being actively discussed right now and may get passed before this session ends, and this session ends very soon. So I'd like to, let's see, I think I have questions now. I'd like to talk to you all if we have time. And I haven't been able to look at the chat because I've been focused on what I'm saying. So if you don't mind, unmute and talk, or I'll try to read some of these chats.
Hey, this is Adrian. So thank you very much for the presentation. And, I'm one that's not afraid to voice an opinion. I'm actually licensed in 2 states where central fields have dominated. One is Florida. And so essentially every chain or majority of the chains, whether it be regionally or nationally, utilize this concept. I'm also licensed and live in Georgia, and Georgia was the last state in the union where mailing a prescription was illegal. So only recently have we legalized mail order prescriptions in the state. And shortly before that law dropped, we passed the central field. Central field does nothing for improving interactions between patients and pharmacists. It does nothing to improve what we call care delivery. What it does do is it just reduces the dependency on labor costs and cut costs overall for the larger chains. So I think that, the consideration of these types of bills, whether it be the central field, whether it be the methadone, whether it be the birth control, it's all targeted to, certain demographics in certain communities that really rely and need to have more clinical input and clinical interactions with pharmacy. So that's my 2 cents. Do I support central field? It is what it is. I just think we as a profession are going to have to go back to block and tackle and what our basics are, which is making sure we're interacting with our patients, making sure that we're ensuring that the medications that we're filling, we're applying the benefit versus the risk ratio, and making sure that we're following the evidence and we're counseling our patients and we're following our patients and we're making sure that we're becoming valued members of the healthcare continuum. Otherwise, this thing is going to continue to grow just like California, and we're going to have vending machines. That's going to be the next phase of this if we as pharmacists do not start coming together to advocate on behalf of our profession and the contribution that our profession can bring to the communities that we serve. That's just me. I'm done. Baptist deacon coming out of me, so I'll go back on mute.
Thank you for that. No, it's very important. What you say is very important and it's true. So appreciate that. Absolutely. Trying to look at some of these chats. Are there any laws in South Carolina restricting the dispense of Suboxone in place of that? Don't think so. They're dispensing both of those and Subutex as well. There are.
Yes, they are dispensing both.
Yeah.
In South Carolina.
Yeah. Number of opioid prescriptions have declined, but there's still an ongoing process of truth. Yes. Yeah, we've had so many sort of, when I was practicing pharmacy in an independent setting, there was I worked through the time where oxycodone was just flowing out the door like crazy, and the feds were putting pressure on the state folks. State folks started to put pressure on us, and restricting and everything, and even in South Carolina or everywhere we have laws now restricting quantities and all of that. But yet we still have a problem. We really do. Seems to be increasing. But one thing I guess I would say is, one thing I noted when I was brand new practitioner, I went to work for an independent, and he was very involved in the association and asked me to join. He asked me to come to a couple meetings, and I did. And that's when I realized, oh, wow, what these folks are actually discussing is going to cause people in charge to perhaps change or to do something. It's going to cause them to act in some way. And I realized real quick that state level advocacy mattered, and it really did. And I felt like, at least in South Carolina, I felt like my vote counted in that organization, and I've seen us do some really cool things, and that translates to the federal level as well. But you can't rest on your laurels, because people, like I said, the quote about being on the menu is so true. There are folks that, as awesome as pharmacists are, there are folks that don't want you in the doors, and so.
And the real, this is Leonard. The real sad thing, am I unmuted?
I hear you.
You are, go ahead.
All right. These people that are passing these laws, they come in contact with pharmacists on a regular basis, but the pharmacists don't, interact with them. And we had a bill last week, and one of the opponents, he said, well, all I do is pull up to the drive-through. They don't do anything. And this was a bill that was going to allow pharmacists to treat UTI infections. Mm-hmm. And in fact, the bill was introduced by an OBGYN because they would prefer the patient seeing the pharmacist rather than waiting for an appointment. But it's those interactions that I realized, because when I sold my pharmacies, I had to go to a chain for a month as a so-called consultant. Mm-hmm. And just the conditions, it made no sense. And this morning, I consult prisons, and the pharmacy tech was talking about how long it took her to get her prescriptions and back up in the queues. So workforce issues, I think, is something we really got to start working on, because we will never move forward until we have a chance really to interact with people. And then another thing, a bill we had here in Virginia, the chains never got involved, and they got involved and came up with a parallel bill that in essence killed our bill. So don't think because you're working for the chain, when I ask people about joining the state association, well, I get my CE and all that. No, you need somebody there advocating for you. And membership in all these state associations are going down, and if things don't change, we won't have anybody, and we won't be a profession, because your PharmD does not make you a professional. It's a state legislator that put on that piece of paper that it's a profession. They can take that away from us.
Right, Leonard, I appreciate that. Yeah, it's very true. And I will say, at least here in South Carolina, I could only choose 3. I didn't choose workplace conditions, but we're trying hard to address that as well. It's tough. When they think giving a lunch break is generous. No, I'm sorry, that's human. That's not generous.
Well, so I'm gonna chime in and say a lot. And I'm so thankful for Dr. Osai, who, depicted puzzle pieces within her presentation, because I think for me, that's what advocacy is. And so, so much to share. And so I see Dr. Maribel put pizza is not working in the chat box. And so if you don't know about Pizza is Not Working, that is a group that's led by Dr. Bled Tanu. I'm working with the group in Texas. And so this might sound all over the place. And so I want to keep it structured, but I'll start there. I believe that advocacy for our profession is synonymous with financial advice that you would get from a financial advisor, right? It is never too late to start saving, right? It's never too late to get involved. You can look at the next person or the next person who's been at it from the beginning, but I know, okay, 2 minutes. So you can look at it from that perspective, or you can start now. So there are 4 organizations that I tell people that they should be a part of. Their alumni association, because your school gave you the opportunity to join this profession and make whatever the opportunities out there. Your state association, because as we see, it's going to drive how you're able to practice. And so Dr. Edlow was absolutely correct when he talked about our profession is really ultimately in the hand of our legislators. But our legislators' role are in the hand of us and their constituents by vote. So it's important for us to understand that. Right. Next is a federal organization, is our federal associations. And I like to position APHA, and I get side eyes when I say it, but APHA as that central voice for pharmacy. If we look at what pharmacies are doing to centralize their operation, we need to centralize our voice. And that doesn't mean that we're blowing out the candle of any of the other organizations, but we need that one solid representation voice. And we need to hold APHA accountable for coming to the various organizations when there's a need or when it's that process. The next is an organization that is how you relate culturally, gender-based, and different things of that nature. For me, it's NPhA, and I've been able to really cultivate intimate relationships with mentors that I can pick up the phone and call at any point in NPhA, and it historically is a Black organization, and I happen to be Black. But there's women groups, there are Nigerian groups, there's Asian groups, there's different pharmacy associations that I think for people who have an interest in senior care pharmacists, they can do that. Because the one thing that I think about when I think about, and I'm working with people that's not working, sometimes it's frustrating because they don't always know the ropes, right? So it's not that they gave pharmacists lunch breaks and they thought that it was a good thing. That's what we went to them and asked for, right? If you look at the posts that are there for you to see, that's what we asked for. When in Texas, I don't know about any other state, but I think in Texas and DC, where I'm licensed, it's already prescriptive for temporary absences of a pharmacist for a certain period of time, right? So it's that. And so we have to be sure that we're understanding, because when we think about the House of Delegates, which NPhA has a seat in for APHA, there's a new business item that's talking about medication assistance programs and prescribing a carve out for pharmacists to be a part of that. So this bill in South Carolina looks to kind of be opposing the policy position statement that we're going to be up against, but that's a pathway maybe for you to leverage what we're saying as a national pharmacy position, that pharmacists should be embedded in that process. So I'm going to try to, stop there, but I think, that Dr. Washington and Dr. Illo, hit the nail on the head. But this is why it's so important, is because there are sometimes we don't know what's happening at the next level. And then therefore we're counteracting, our push. I'll end with the fact that, one article, it's not really like a peer review article. It was a commentary and like a drug topic, was from Fred Eccles in 2011. It is the one article that really tells the pharmacy profession is do not look at immunizations as a commodity. And the one thing that we did was we looked at immunizations as a commodity. And what that did was the domino effect that our overall profession, everything that we do is commoditized down to the minute, to the second a pharmacist interacts with a patient. And so it's important for us to, when we have the ability to engage with that patient, that we're telling them the value. And I'll even say it because I don't think we say it enough, that we approach that person as Dr. whoever we are. I think the first name basis, to provide comfort for them, I think that's hogwash. We need to come to them and they need to understand who we are and what our credentials are and how that's different than a technician, how that's different than a nurse. So then therefore they can help us advocate for a better profession. Because if you know the history of physicians in this country, they were not always respected. So I'm going to end there. So, because I know I might.
Thank you, Dr. Noor. Thank you so much. We appreciate it. And thank you, Dr. Shirley. I'll pass it on to my moderator, future Dr. Dazen Perry.
Okay, so after this amazing discussion, I want to thank Dr. Shirley for discussing legislative topics specific to South Carolina, but that can also translate to different areas in pharmacy. So thank you so much. If you do have any additional questions, the contact information for myself and the speakers for tonight, as well as the additional moderator, will be on the slides coming forward. And again, thank you all so much. I'm going to pass it off to Sienna. Dr. Miller, I'm sorry.
You are fine. Thank you. This will be very, very brief. I want to have many thanks to Dr. Osai and Dr. Shirley for their contribution to legislative challenges impacting our minority and underserved communities. Through this event, we hope, which I felt like tonight we did, but through this event, we hope to spread awareness, educate, and advocate for issues regarding our community. Thanks to all of you for joining us this evening. As a reminder, any unanswered questions or concerns can be sent to our presenters, Dr. Sharmon Osai at sharmon.osai@uga.edu, Dr. David Shirley at shirleyd@musc.edu, or to me at cnnmiller@npha.net, or to future Dr. Jasmine Perry at jasmine.perry@snapha.org. I'll give you a couple minutes to take a picture or a screenshot, or remember to write down the email. And if not, you can always email me later on for their emails. We hope you will join us again in the future for our next joint NPhA and SNPhA legislative event, as we will have another exciting and informative session planned. Have a great evening and be well. Good night.